Every treatment relationship you enter carries within it the possibility that it will need to end before the patient wants it to. That is not a failure. That is arithmetic. You are balancing two quantities that change over time. The probability that your continued involvement will help this patient, and the probability that your continued involvement will harm this patient, harm others, or expose you to professional and legal risk that compromises your ability to help everyone else on your caseload. In the beginning of most treatment relationships, the balance is obvious. The patient needs help. You can provide it. The risks are manageable. The trajectory is forward. But as treatment progresses, especially with complex patients, that balance can shift. The likelihood of benefit decreases. The risks accumulate, and at some point you reach what I call the inflection point, the moment where continuing treatment is no longer serving the patient's interest or yours, and may in fact be actively working against both. Now, here is what makes this so difficult. That inflection point is not a permanent state. It may arrive, persist for weeks or months, and then recede. A patient who has been non-compliant and hostile may suddenly re-engage. A patient who has been diverting medication may, after confrontation, genuinely change course. The tipping point flickers, it comes and goes. And because of that, the decision to terminate feels premature at every moment you are considering it and obvious only in retrospect. You must learn to tolerate that ambiguity and act on your best clinical and legal judgment despite it. Let me be very direct. There is a legal duty not to abandon a patient, but there is an equally important and often overlooked legal duty not to continue ineffective or dangerous treatment. Continuing to treat a patient long after the treatment has become futile, counterproductive, or dangerous is not dedication. It is malpractice wearing the mask of compassion. So when does termination become not only permissible but necessary, even when the patient objects? Let me walk you through the situations you will encounter. 1. The patient who repeatedly runs short on controlled medication. You prescribe a 30-day supply. They call at day 20 saying they are out, or day 15, or day 10. You counsel them, you document the counseling, you explain why early refills are clinically dangerous, legally problematic, and a signal that something has gone wrong, whether that is misuse, diversion, or an escalating tolerance that demands a different treatment strategy. You offer alternatives: substance abuse treatment, a slow supervised taper, replacement with a non-controlled medication that addresses the same symptom cluster, and they refuse, or they agree and then repeat the behavior. Here is what you must understand about this situation. A patient who is consistently running through controlled medications faster than prescribed is a patient whose safety you cannot guarantee. More than that, every prescription you write with your name on it is a legal document. It is a representation to the pharmacy, to the DEA, to the state medical board, and to any future court that you made a clinical judgment that this patient needs this medication at this dose, at this frequency. When the patient's actual consumption pattern bears no resemblance to what you prescribed, that prescription becomes a fiction, and a fiction with your signature on it is a liability. Your mission, the only mission that justifies holding a medical license, is to improve this patient's short-term and long-term prospect of not merely staying alive, but thriving, surviving and having a meaningful life. If the patient is not a willing participant in that mission, then there is no mission. They must either comply with a modified treatment plan or seek treatment elsewhere. 2. Diversion. Selling prescribed controlled medication. This is a federal crime. It is also a clinical and ethical emergency for you, but the response is not as binary as you might think. There is a meaningful difference between a patient who is selling 100% of their prescription, a patient selling 50%, and a patient selling 10%. The patient selling the entirety never had a therapeutic relationship with you. They had a supply chain arrangement. That is immediate termination. There is no clinical justification for continuing to be a wholesale distributor for street pharmacology. The patient selling 50%, half their medication going into their body and half onto the street, is more complicated. They may have real pathology. They clearly need some of what you are prescribing, but they are also making you an unwitting co-conspirator in a felony. The patient selling 10%, shaving a few pills off the top each month to make rent or buy groceries, is the one that will keep you up at night, because this patient may be desperate rather than criminal. They may be living in poverty so grinding that diverting 3 pills a month is the difference between electricity and darkness. You must confront this. You must document it. You must offer alternatives, social work referrals, patient assistance programs, non-controlled substitutions. But you cannot look the other way. because the moment you suspect diversion and continue prescribing without addressing it, you have crossed a line that no amount of empathy will uncross in front of a medical board. And then there are patients who have genuine pathology requiring treatment, but who are also manipulative, calculating, even ruthless. Severe personality pathology coexisting with real Axis 1 illness. These patients will test you in ways that no textbook prepares you for. They will cry real tears and fabricate real stories. They will appeal to your compassion with surgical precision. The question is not whether they are suffering, they usually are. The question is whether your continued prescribing is contributing to their well-being or to their capacity to harm themselves and others while giving the enterprise a veneer of medical legitimacy. When the answer shifts to the latter, the treatment must end. 3. Abusive behavior directed at you. Repeated verbal insults, racial slurs, gendered obscenities, threats of complaints to the medical board used as leverage, threats of negative online reviews used as coercion, and at the far end, threats of physical violence. Let me give you some numbers because numbers concentrate the mind. The rate of non-fatal violent crime for all occupations in the United States is approximately 12.6 per 1,000 workers. For physicians generally, it is 16.2. For psychiatrists and mental health professionals, it is 68.2 per 1,000, more than 5 times the rate for other physicians. Between 40 and 50% of psychiatry residents will be physically attacked by a patient during their 4 years of training. Over the course of a career, the assault rate for psychiatrists ranges from 5 to 48%, depending on the study and the setting. As for the ultimate violence, a study published in the Journal of Clinical Psychology analyzing National Violent Death Reporting System, data from 2003 to 2020 identified 944 homicides of health professionals in the United States. 8 of those victims were psychiatrists, and half of those 8 were killed by patients or family members of patients. A separate systematic review found that among physician homicides generally, 39% of the victims were psychiatrists, despite psychiatrists representing roughly 1% of the physician workforce. Researchers have estimated that a mental health professional is murdered by a patient approximately once every 2 to 3 years in this country. Wayne Fenton, beaten to death by a 19-year-old patient with schizophrenia in his Bethesda office in 2006. Catherine Fogay, attacked with a meat cleaver by a patient in her New York office in 2008. Mark Lawrence, shot dead by a patient in his home office in McLean, Virginia in 2011. Caroline Ekong, murdered in her home in Delaware in 2015 by a former patient who had been obsessing about her for 3 years. These are not abstractions, these are colleagues. Now, physical threats that are credible and imminent, that is the domain of law enforcement, and you should not hesitate to involve them when your life is genuinely at risk. But I will say this, a physician filing criminal charges against a patient is a deeply undignified spectacle. It lowers the reputation of the individual physician, and fairly or unfairly, it casts a shadow over the profession as a whole. It should be reserved for situations of genuine and immediate danger. For lesser abuses, chronic verbal hostility, demeaning language, manipulative threats, the appropriate response is not a police report. It is termination. You are not obligated to absorb psychological abuse as a condition of holding a medical license. 4. Chronic no-shows and non-compliance. The patient misses appointments. When they come, they have not taken their medication or have taken it erratically or have supplemented it with substances that negate its effect. You warn them, you document the warnings, you reschedule, they miss again, and meanwhile, their condition is deteriorating and you are the physician of record. This is the scenario that should concern you more than any other, because if that patient harms themselves or someone else, your name is on the chart, and the question the plaintiff's attorney will ask is not why did you terminate? The question will be why did you continue to nominally treat a patient whose behavior made effective treatment impossible? You were providing the illusion of care, and the illusion of care may be worse than no care at all because it gave everyone, the patient, the family, the system, the false assurance that someone was watching. Return to first principles. Your purpose is to extend life and improve its quality. A patient who repeatedly refuses to participate in that effort, who will not show up, will not take their medication as prescribed, will not stop using substances that undermine treatment, will not engage in therapy, will not follow safety plans, that patient has withdrawn from the therapeutic contract. You cannot execute a contract alone. 5. Secondary gain exploitation. A patient who is using your practice primarily to obtain documentation for disability claims, custody battles, legal cases, or other secondary gain purposes while actively sabotaging the treatment that would make such documentation unnecessary. When the consultations have become document factories rather than treatment sessions, you have ceased to function as a physician and become a notary with a prescription pad. 6. Irreconcilable conflict of interest. A patient who has filed a malpractice complaint or board complaint against you. At that point, the therapeutic relationship is dead. There is no trust left to build on. Continuing treatment creates a conflict of interest so severe that no competent attorney would advise it. The patient needs a new clinician. You need a clean separation. 7. Exceeding your scope of competence. The patient's clinical needs have genuinely outgrown what you can safely provide in your practice setting. They need a higher level of care, a specialist you cannot replicate, or a treatment modality you are not equipped to offer, and they refuse referral. You are not helping this patient by pretending to be something you are not, and if the outcome is poor, the fact that the patient refused referral will be cold comfort when the board asks why you continue to practice outside your competence. 8. Insurance termination with refusal of alternatives. The patient's insurance has ended. They cannot pay, and they will not accept a referral to a sliding scale clinic, a community mental health center, or any other alternative. You are not obligated to provide indefinite pro bono care. You may choose to, that is your prerogative, and it speaks well of you, but it is not a legal or ethical requirement, and your practice cannot sustain itself on charity cases that refuse to be redirected. Now, let me shift to the mechanics of how you do this properly, because the difference between termination and abandonment is not what you decide, it is how you execute. Abandonment, in the legal sense, is the unilateral severance of a physician-patient relationship when the patient still needs treatment, has no substitute care arranged, and suffers harm as a result. Every word in that definition matters. Your job is to make every element of it inapplicable. And here is a critical point many clinicians overlook. A patient voluntarily transferring to another clinician is always preferable to you terminating treatment. When a patient ends the relationship themselves, there is no legal basis for an abandonment claim. None. This is why, whenever possible, the conversation should begin not with, "I am ending your treatment," but with, "I believe you would be better served by a different provider, and here is why." Frame it as a clinical recommendation, not a rejection. A patient who feels heard and respected is far more likely to walk out voluntarily than one who feels discarded. Guide the departure. Do not shove. But when voluntary transfer is not possible, when the patient refuses to leave, refuses referral, insists on continuing under terms that are clinically or legally untenable, then you must proceed to formal termination, and the procedure has specific non-negotiable requirements. First, know your state law. Every state has its own requirements for ending the physician-patient relationship, including the minimum notice period. 30 days is the most common standard, but some jurisdictions require more. Check with your state medical board. Consult your malpractice carrier. Second, communicate the termination both verbally and in writing. The written notification must include the effective date of termination, the reason or reasons for termination stated in clinical rather than accusatory language, a clear statement that the patient continues to need treatment, at least 3 referral resources, and these do not need to be specific physicians who have agreed to accept the patient. They can include community mental health centers, the APA's Find a Psychiatrist tool, the patient's insurance panel, and a reminder that emergency departments are available for psychiatric emergencies, and the date after which you will no longer be available as their treating physician. Third, provide prescriptions to carry the patient through the termination period, typically 30 days, but not beyond, and with no refills. This is critically important. A prescription written after the termination date is de facto evidence that a treatment relationship still exists. Be conservative, especially with controlled substances. Do not prescribe large quantities around termination. If the patient has an adverse reaction to a medication you prescribed but is no longer under your care, you may still be found liable. Fourth, document everything. Your chart should contain every warning you gave, every alternative you offered, every instance of non-compliance, every conversation about the risk of their behavior, and the full text or a detailed summary of the termination letter. If this case ever reaches a courtroom or a medical board hearing, your documentation is your defense. What is not documented did not happen. I will say that again. What is not documented did not happen. Fifth, do not terminate a patient who is in acute crisis. If the patient becomes acutely suicidal, psychotic, or otherwise decompensated during the termination process, the termination is suspended until the crisis is resolved. Through stabilization, hospitalization, or transfer to emergency care, you may resume the termination afterward. But severing a relationship with a patient in crisis is the single fastest path to an abandonment finding. Sixth, after termination, if the patient contacts you, respond once in writing, reiterating the termination, the referral resources, and the availability of emergency services. Then do not engage further. Continued back and forth communication after termination blurs the boundary between an ended relationship and an ongoing one, and that ambiguity will not serve you. One more thought. There is a myth in our profession that terminating a patient is an admission of failure. It is not. It is an acknowledgement of reality. Not every patient will benefit from your care. Not every therapeutic relationship will work. Some patients will defeat your best efforts not because you were inadequate, but because they were not ready or not willing or not able, given the particular architecture of their pathology and their circumstances. Knowing when to let go is not the opposite of caring. It is the mature expression of it. A physician who holds on to every patient out of guilt or fear or misplaced heroism is a physician who is slowly drowning than taking the rest of their caseload down with them. So terminate thoughtfully, terminate legally, terminate with documentation that would make a law professor gasp of admiration, and then turn your attention to the patients who are ready to do the work, because they are the ones who will make your career worth the considerable trouble of having one.